I will introduce our second speaker is Professor Hiroyuki Kanao. Hiroyuki Kanao is currently the director of Gynaecology Cancer Institute JFCR, Tokyo, Japan. He is also a member of JSGO, GSGO, and the JSES and the JSCC. Today, Dr. Kanao will be sharing with the youth with us on how to improve the surgical outcome in radical hysterectomy. Professor Kanao, please.
Okay, thank you for the kind introduction, Chairman. Can you hear me? Okay. Actually, in Japan now, we have a very difficult stage of the COVID-19 pandemic. I hope this pandemic will be settled down as soon as possible. Anyway, today I want to talk about the I want to talk about the how to improve the surgical outcome in the radical hysterectomy. As you know quite well, the RAC trial, the randomized control trial, minimally invasive versus abdominal radical hysterectomy for early-stage cervical cancers, demonstrate the inferiority of the minimally invasive surgery. However, the surgical trials are difficult to successfully undertake because it poses there are several confining factors, such as the pre- and post-operative cares, skills of surgeons, and surgical procedures. About the surgical procedures, it's already discussed, and we have a certain conclusion. Maybe a cancer cell spillage into the peritoneal cavity may cause the result of the RAC trial, and the protective maneuver of cancer cell spillage into the peritoneal cavity is a very important issue. So, usage the uterine manipulators and intracorporeal colpotomy may cause the cancer cell spillage into the peritoneal cavity, and circulating CO2 gas and the Trendelenburg positions may exaggerate this bad effect. So, during the minimal invasive radical hysterectomy, multiple pelvic recurrence occurred. The second studies demonstrated that the minimal invasive radical hysterectomy without the usage of the uterine manipulators and with the protective colpotomy may demonstrate a similar oncologic outcome with their open procedures. A little bit difference, okay. So, how about the skills of surgeons? Intuitively, the skilled surgeons can demonstrate a good oncologic outcome. Is it true? This report demonstrates a good correlation between the surgical skills and the post-operative complication rate in the bariatric surgeries. And post-operative complication may worsen the oncologic outcome in the colorectal cancers and in the gastric cancers, and also in the esophageal cancers. So maybe in the cervical cancers, post-operative complication may worsen the oncologic outcome. It is so-called surgical oncotaxis. Post-operative complication contribute to enhancing the tumor metastasis, resulting in a poor prognosis for cancer patient. So it is very important to prevent the post-operative complication to secure the good oncologic outcome in the cervical cancers. As you know, in the open procedures, the association of radical hysterectomy surgical volume and survival can be observed. So maybe in the laparoscopic radical hysterectomy, skilled surgeons can demonstrate a good oncologic outcome. So what is a skillful radical hysterectomy? Freeze emerging egg means the uterus with the cervical cancers, and the birth nest means the adipose tissue around the uterus. So which is the better skillful laparoscopic radical hysterectomy? Of course, this one is better. So this is the no look, no touch technique. In these procedures, it is very important to prevent a traumatic tumor handling. So during the radical hysterectomy, it is necessary to prevent the traumatic handling of the cervix because it may cause the cancer cell splash into the peritoneal cavity. A little bit strange. And I think it is very important to remove all of the adipose tissue around the cervix in their colorectal cancers and in the cervical cancers. Adipose tissue around the cancers may contain the cancer cell. So to remove all of the adipose tissue around the cervix is also the very important issues. Can you see the videos? Actually, this video demonstrates the final operation view of our no-look, no-touch laparoscopic radical hysterectomy. Actually, in this case, the tumor is under the 2 centimeters, so the low risk of the cervical cancers. So we perform the nerve-sparing laparoscopic radical hysterectomy. Actually, around the teeth of the cervix, so it means the rectum, bladder, nerve, and the vessels. Completely removal of the adipose tissue around these organs. It is very important to secure the good oncological outcome. So from now on, I want to introduce our no-look, no-touch laparoscopic radical hysterectomy. This case is for the stage 1B1, the cervical cancer. The tumor size is under the 2 centimeter, is a very low risk of the cervical cancer. Please enjoy these videos.
Surgery with a patient under general anesthesia and in the rhestotomy position. A vaginal cuff is created. 12 to 15 sutures are placed circumferentially, approximately 2 centimeters from the tumor, and the sutures are pulled to reveal the incision line. Dilated adrenaline is injected into the incision line to minimize bleeding. The vaginal mucosa is then incised circumferentially with a monopolar electrocautery device, leaving the vaginal cuff that is closed with a double layer of continuous sutures. A 5mm extra long trocar is placed at the posterior vaginal pharynx, and the forceps are introduced through this pod. A 1/0 bicular suture is placed around the uterine body, and the forceps are used to push and pull the suture to manipulate the uterus without the uterine manipulator. Essential to radical hysterectomy is the creation of wide paramedical and pararectal spaces to expose and reject sufficient parametrum. In some cases, such as the case of an obese patient or a patient with a bulky tumor, the operative view is poor, so the uterine cervix must be squeezed medially and laterally to expose the parametrum. Sometimes parametrum can be sufficiently exposed by suspension of the rectum and umbilical ligament from the abdominal wall, avoiding the need for squeezing the uterine cervix. A vascular space between the mesorectal fascia and the presacral fascia is dissected and developed. the inferior hypogastric nerves and the pelvic nerve flexes are identified and preserved. The rectum is then lifted with the assistant forceps and peeled away from the surrounding tissue down to the levator-ani muscles. To expose the right side parameter, the rectum is lifted towards the left side, and the umbilical ligament is lifted towards the right side. This suspension technique helps develop the paravesical and pararectal spaces and provides for both safe and sufficient resection of the parametrum without handling of the uterine cervix. After the resection of posterior layer of vesico-uterine ligament is completed, pelvic nerve networks can be exposed. Palpopian tissue is sutured and resected above the hypogastric nerves, which can accomplish the nerve-sparing radical hysterectomy. Colpotomy is conducted laparoscopically. However, cancer cell exposure to circulating CO2 gas can be prevented because the vaginal cuff is created before laparoscopic surgery. A correction bag is used for retrieval of the uterus and lymph node. Shown in this supplementary video, our no-look, no-touch laparoscopic radical hysterectomy, which incorporates 4 techniques for prevention of cancer cell spillage: creation of a vaginal cuff, manipulation of the uterus without insertion of a uterine manipulator, minimal handling of the uterine cervix, and bagging the specimen is technically feasible.
So then we compare the operational result of the 113 cases of no-look, no-touch groups, and 118 cases of abdominal radical hysterectomy, which were performed during the same time. Actually, the operation time and the blood loss is no-look, no-touch groups show the shorter operation time and the smaller blood loss volume. About the intraoperative and post-operative complication are similar between the two groups. And actually, the background of the patient is a little bit different. Younger patients with smaller tumor size tend to perform the no-look, no-touch laparoscopic radical hysterectomy. So, to adjust these background differences, we use the IPTW method. After adjusting the background of the patient, the Kaplan-Meier curve shown the result. Actually, the 4.5-year disease-free survival between the two groups, there is no statistical difference. And about the overall survivals, there is no statistical difference between the two groups. And the tumor size over the 2 centimeter, it means the high-risk recurrence groups. There is also the statistically no difference between the two groups. And then we examine the heterogeneity between our study and the LAC trial. Actually, the I-square is about the 60%. It means that our study may be different from the LAC trial. However, the number of the event is so small, there is no statistical difference. Based on these our experiences, we conclude that the difference from the LAC trial, our result indicate that total laparoscopic radical hysterectomy performed by experienced surgeons, which incorporated specific measures aimed at preventing tumor cell spillage, is a reliable alternative procedure to abdominal radical hysterectomy. Thank you for your attention.
Thank you, Professor Kanao, for the wonderful lecture. Now we will start the Q&A. Are there any questions from the audience regarding the radical hysterectomy? Please type into the Q&A box. I can ask Professor Kanao.
Yes.
Because I noticed at the start you have already closed the created the vaginal cuff, closed the tumor. So is it necessary to actually put the whole specimen to a bag and then pull out? Why not just pull out the entire uterus and cervix through the vagina using the sutures that are already present on the vaginal cuff that you have made?
A little bit difficult to hear, so please say again.
Yeah, my question is it necessary to use a bag at the end of the surgery remove the specimen?
I see. Okay. Actually, if the tumor, if the uterus is a little bit big and the vagina is a little bit small, sometimes I squeeze the uterus when we retrieve the uterus directly. So squeezing the uterus may cause a cancer cell spillage, even we create the vaginal cuff. So we completely prevent the cancer cell spillage. So we create the vaginal cuff, then we use the plastic bag when we retrieve the specimen.
Thank you. Any questions from the audience? Okay, there's one question. question was on, did you perform a pathological comparison? I'm not exactly sure what this question means. But another question is, how many surgeons in Japan are still doing laparoscopic radical hysterectomy? Even though is there any change to open surgery?
Actually, some institution completely changed to the open, and some institution still continue to perform the laparoscopic surgery. Maybe it depends on the experience. If the surgeons are confident to perform the laparoscopic radical hysterectomy and they have their own data to show the similar result of the laparoscopic radical hysterectomy, maybe they continue to perform it. But a little bit difficult to just start the laparoscopic surgery because the LAC trial already demonstrated the inferiority of the minimally invasive surgeries, and the Japanese commercial already reported this result. So a little bit difficult just start to the laparoscopic surgery. Maybe 20% of the hospital still continue to perform the laparoscopic radical hysterectomy.
I think this is all the same situation in my country as well after the LAC trial has been published. So hopefully the new trial that's coming out will give answers to whether we can still continue to do the laparoscopic radical hysterectomy.
Yeah. Now we just started the clinical trial to evaluate the oncological outcome of Japanese laparoscopic radical hysterectomy. We just started.
That's great. Another question is, what is the average duration of the surgery?
In my case, actually my case is about the 4 hours to perform this laparoscopic radical hysterectomy.
What is the learning curve? The number of cases that you believe needs to be, practiced before you think that a person will be well trained enough to do the laparoscopic radical hysterectomy?
I see. Depends on the talent of the young doctors. But maybe 30 cases is enough to perform this no-look, no-touch technique. Actually, my institution is the biggest cancer center in Japan. So annually, we perform the 150 cases of the radical hysterectomy. So very easy to master this technique. However, some institutions only have the 5 or 10 cases. So depend on the institutions, they are a little bit difficult to master these techniques. So, but about average, 30 cases is enough to master this technique.
The next question is, what is the limit of tumor size in performing laparoscopic radical hysterectomy?
Actually, in my data, the 4 centimeter is a limit. Over the 4 centimeter, a little bit difficult to completely prevent the cancer cell spillage, even we create a vaginal cuff. So under the 4 centimeters, so I mean the 1B2, the cervical cancers, we always perform the open procedures.
Thanks. And I think this is a final question. How can you explain for the 2 groups of your study with different surgeons so that result from the laparoscopy group may result in better results because of a skillful laparoscopy?
Actually, this data in this data, the no-look, no-touch technique, all the procedures are performed by me. So I'm not sure different doctors, different result or not. So now we just started the clinical trial of these techniques. So there may be 15 to 20 Japanese institutions enter this clinical trial, then perform this no-look, no-touch technique, then try to demonstrate the similar oncological outcome of the open procedures. So I'm very looking forward to this result.
Thank you very much, Professor Kanao.